To the last video lecture that addresses pediatric cancers. This lecture is a compilation of a couple types of cancers. We're going to start with the Wilms tumor, which is also known as a nephroblastoma. It's a solid tumor, and it's the number one tumor affecting the kidneys in a child. And it accounts for about 7% of childhood cancers. Remember, leukemia is the most common. It can be associated with other congenital anomalies. In my experience, I've never seen a congenital anomaly along with a Wilms tumor. It's typically just the Wilms tumor. So this is a tumor that affects younger kids. By the time the kid is 7 or after age 7, it's very rare that we will see a Wilms tumor. It can be bilateral, but usually is unilateral. And this is the one that if we can keep it encapsulated within its capsule, no matter how big it is, they have a pretty good prognosis. The diagnostics are going to be an ultrasound because we're going to see a big mass. When we see that big mass, then they're going to order a CT scan and an MRI. We'll look at the CBC. Generally, these kids are going to show an anemia, and we'll look at the chemistries. And on this chemistry, the renal function is going to be very important. So look at your BUN and creatinine and see how well these kidneys are functioning. And then we'll get a urinalysis. You can see on the picture on the right where the Wilms tumor is. Look at the size of the tumor on the right side. That thing is huge. When you look at the CT scan, the double white arrow shows where there is part of the normal kidney, but then where the single arrows are, that is all tumor. Because the majority of these are unilateral, when you palpate the abdomen, we'll have a mass just on the one side. But remember, don't press too hard because it is encapsulated. We don't want it ruptured and then seeding into the belly. They may have hematuria. They'll have anemia. They're going to look a bit pale because of the anemia, and they're going to be tired. The mother may complain of constipation. They'll have abdominal pain, and then they'll have those low-grade fevers. These kids, because they develop hypertension, because the renal function has been affected, we'll give them meds for hypertension, and then they end up having a nephrectomy. And you can live very well on one kidney. However, we don't want this child to be getting urinary tract infections because a UTI can end up being a pyelonephritis. This kid only has one kidney. We want to preserve it. So part of our patient education in the long haul is to avoid anything that can cause a urinary tract infection. The next cancer we're going to talk about is going to be very brief on testicular cancer. You're going to hear more about testicular cancer in Nursing 174. It occurs in adolescents to young men, and the risk factors are having undescended testicles. Half of the testicular cancer presents after metastasis because these young boys are afraid to tell us that anything's wrong. So they have the groin pain, they reach down, they touch, and they feel something, and it's like, well, I'm not sure if that's normal or not normal, and man, this is my private stuff. I am not showing anybody. Then they come in and they have metastatic disease. So the best thing that we can do is self-testicular exam. We teach this to our adolescent boys. Don't you love the little cartoons of the guy who feels it in the bathtub and then immediately gets on the bike, no clothes, and goes straight to the doctor? And then the last cancer we're going to talk about is the retinoblastoma. And the hallmark of this cancer is what we call leukocoria, where the white reflex has replaced the red reflex. And you can only see it on certain angles, but it's amazing. This is the cancer that the parents notice. Oh my goodness, every time I look at my child's pictures, they only have a red reflex on one eye. And they might come in just for a well child exam and the pediatrician finds it, but they can figure out when this tumor started based on the parents' photographs of the child. The child may have a strabismus where the eye is going towards the inner canthus. There can be pain and redness around the eyes and a change in the child's ability to see. We treat a retinoblastoma by doing surgery. They may need to do full enucleation of the eye. and it's followed by chemotherapy and radiation. They can use a phototherapy to destroy all the blood vessels that were supporting the growth of this tumor, and then also use cryotherapy to destroy the tumor. Eventually, the child will be fit with a prosthetic eye, and then they have to be trained so that they will continue to close their lids. And I'm not sure if they move. I have only seen one, and that one did not move. So we're going to need supportive care. The child is going to learn to see with one eye, but when they had that tumor in the eye, their vision was impacted anyway, and it's possible that they have already adapted to the one eye. We may give antibiotics just to prevent infections, and then these kids are going to go home. And this ends the lecture series on childhood cancers. Thanks for listening.